Hello, very good evening, and welcome all to the special edition of this classroom. Today, we have none other than Professor Dr. H. Dash and Dr. Virendra to discuss on the practical experience of what we face during these situations. We are faced with a very uncertain situation. We don't know which patient coming to the neuro emergency is an important part of the emergency healthcare is COVID or non-COVID. So in this scenario, how to go about in approaching these neuro emergencies? Neuro emergencies are time sensitive. It should not be delayed because for the lack of testing for COVID. At the same time, we are in a responsible position to protect ourselves as well as the healthcare workers who are working for the patients in not contracting the illness. So with this context, there are few cases which Dr. Virendra will share. We have an expert, none other than Dr. Dash here. Along with Dr. Dash, Dr. Prasanna also will join, and we'll be discussing that in today's classroom. So may I welcome Professor Dash and Dr. Virendra for the show. Welcome, sir. I'm so glad to have you here. Welcome, Virendra. And Dr. Prasanna is joining for the moderation. Welcome, Dr. Prasanna.
Hello, Punaya. Okay.
Sir,
Yeah.
Professor, sir, can you just brief about the current scenario, how our practice has changed, and what are the things we need to adapt? Because there is generally a certain anxiety among the practitioners, especially when they deal with emergencies, when we don't know what we are going to foresee. So, how to go about with this uncertain future in these times, and how to go about with our practice during these times? Few words for us, sir.
Uh, Good evening, everybody. I must at the outset express my sincere thanks to our bunch of, or the Dr. Puneya and Dr. Prasanna, who are ever ready to take the challenges for the ISNAC group. I'm really sincerely thanks both of them for organizing this webinar in a very short time. My sincere thanks also goes to the people who will be joining soon to listen to our experience of managing these emergency cases, be it positive, be it negative. Uh, During this COVID-19, one thing came to my mind, like we always teach the students about the head injury, status epilepticus, and subarachnoid hemorrhage, about the central cholinergic surge, how it affects the cardiovascular changes or the systems and the ECG changes and echocardiographic findings. Similar things happen in COVID-19 patients that goes under the name of cytokine storm. The cytokine storms are nothing but the immunomediated cells. They pour out massively the substances which affects the human organs, different organ systems, and which has been thought to be the cause of death in severe patients. So how to take care of those, of course, that is not our domain because those things happen only in serious cases. But another thing I must tell you, this COVID-19 not only has devastated the whole country, the economy, social infrastructure, but at the same time, these epidemics and pandemics are harbinger of new inventions. And particularly this COVID-19, the most important invention from the anesthesia and surgical point of view is how to prevent aerosolization during airway manipulation so that the health care workers, particularly the anesthesiologists, the surgeons, the nurses and the technicians are safe. In our institute, we have the idea was given by Dr. Virendra and us, and it was implemented by our who has got not only got nimble surgical fingers for carrying out good surgery, he has also technical mind and technical abilities, and who has really devised a very good device that will be shared by Dr. Virendra Jain very soon. And lastly, I want to inform the audience or the people who are listening, please go through this recent article which has come on, has been published online, the Lancet 29th May 2020, where they have actually carried out a international multi-center cohort. 235 hospitals were involved and in 24 countries, and they found out the incidence of mortality and morbidity within 30 days of surgery, where the patients were detected within 7 days or detected within 30 days. The mortality was around 30%, and the complication rate, 30 days mortality, was around 50%. And the other things, ASA grade and the age and the male, I think those you must go through. And now I request my dear colleague, friend, and student, Dr. Virendra Jain, to present our experience with COVID positive and suspected patients and how we have prevented aerosolization during airway manipulation. Thank you.
Thank you for your remarks, sir. Dr. Virendra, so you are going to present some cases what you have done?
Yeah.
So
And
basically,
not only we have devised, and how that device is very useful, that you will be demonstrating with, we have done some measurement that you will be sharing with you.
so basically, what I'll be discussing today is we had one patient who was COVID positive, another patient who was COVID positive, second report came negative, and two DSA cases. What problems we faced, how we encountered them, what are the protocols that we have set up for, especially for neurosurgery, getting all these patients operated even in emergency, and like in stroke, time is golden time. So how to get them to the DSL lab without any hassles of anybody thinking that, oh, he might be COVID positive. What are all the protocols have been set up? We have a very good hospital support also. So how all these procedures have been implemented, SOPs, protocols, and how we are getting all these cases done, and how all the outcomes that we are seeing. So I'll be sharing what problems we had faced many problems in implementing these things. We have devised new aerosol prevention devices. So how we are using, how the surgeons they have been using, how to validate this thing, that whether it is effective or not. So all those things we are now trying to develop this thing and show that okay, something is beneficial for both, for all the healthcare personnel in OT. So how this thing can be beneficial. So I'll be sharing all my experience in next half an hour in this thing. Oh, so so I'll be starting with my PowerPoint.
Okay.
Okay. Good afternoon, everyone. Across India, COVID-19 patients are increasing. We all have developed at our respective places one or other protocols for handling such patients. whether it is an elective case or whether it is an emergency. So I'll be sharing at what our experience of handling neuro emergencies in COVID-19 positive and suspected patients uh, in the in the next 30 minutes or so. I'll be sharing regarding my something regarding the background of COVID-19. Why, as neuroanesthesiologists, we should be concerned, especially for COVID-19, how to why aerosolization is dangerous for all the OT personnel. Our experience of COVID-19 positive and suspect patients, what SOPs and protocols are in place, how we have developed and utilized barrier devices for aerosol prevention in operation room, and what are the problems encountered, or how we have evolved our SOPs in the coming days. We all know that uh, this SARS-CoV-2 originated in China, later named as COVID-19 by WHO. WHO declared it as a global pandemic, and the spread has been unabated since January all over the world. All the major healthcare, all the major economies have faced a severe economic crisis, healthcare crisis, and still it is spreading worldwide. Looking at the Indian data till yesterday, we have a very large number of cases. The good point is that our fatality rate is quite low and our recovery rates are good. But as we can see in this bar diagram, that since last 14 days, our numbers have been continuously increasing, and many epidemiologists still feel that the peak in India is still to come. So we'll be seeing more and more patients in coming days, whether in all the places. So why we should be concerned in neuroanesthesia? We all know that droplet infection is the mode of spread, but my major concern is many of these patients are asymptomatic. So while you are taking a clinical history, you still might miss the symptoms, and precautions need to be taken while handling these patients when these patients come in emergency and we don't have a confirmed status. The use of general anesthesia, use of high speed drill during neurosurgery, extensive cautery use, ultrasonic aspirators, all these are very large proponents of aerosol generation and can be detrimental to creating a exposure. Also, the use of mechanical ventilation post-op and the need for tracheostomy in these chronic patients can be a potential exposure and can lead to it all forms a recipe for a potential breach and leading to a hazardous exposure. So we all are now used to this new normal. We all have been, because of the mass media coverage, extensive guidelines, and the most importantly the WhatsApp information. Now we are all used to this PPE and the personal protection devices for all of us. Our approach has changed. In my last 20 years of anesthesia experience, what I think that all these things I've been following, but in last 3 months and especially in last 1 month, I've understood that it is not the one man's show. It has to be a coordinated and sustained effort at all levels. The hospital has to form a policy, our surgeon colleagues have to pitch in, nurse, especially nurses in ICU care, everybody has to pitch in and form the utmost level of prevention so that no breaches happens and we are all safe, because if one person gets affected, it can affect many more in the coming days. So we have plethora of guidelines, we have n number of guidelines, but these are some good guidelines which have been suggested for neuroanesthesia practice. But my personal favorite is the Sri Chitra Group guidelines, because they have given a very systematic approach to how to approach a patient of COVID-19, whether doing an elective case or an emergency case. So the need of the hour is it is the commitment on part of both the policymakers, hospitals, and the healthcare workers in the hospital to utilize the best resources and form a local policy, seeing the available resources for the treating these patients. So we'll be sharing our experience of first few COVID suspect and confirmed cases along with the challenges we faced and the loopholes how we identified and plugged them. We all know Delhi NCR is a red zone with large number of patients, COVID-19 patients, and this number has been increasing over the last 7 to 10 days. So since last in since before the lockdown happened, the at our hospital we had formed a COVID-19 policy SOP was put in place, in which we have identified how the patients will be coming, how they will be identified, they will be confirmed, what we will be doing in suspected cases, how the emergencies will be happening, and this protocol was laid even before the lockdown happened because we cater to a lot of international patients. But even after the lockdown, all these policies have been strongly followed, and we are able to achieve a good. So when a neurosurgical patient comes to any patient comes to an emergency room, it is identified. If it is a surgical emergency, then it goes to a dedicated COVID OT. Dedicated COVID OT, it is as per the recommendation, it is a separate OT from the normal OR complex. It has a separate entry and a separate exit, negative pressure OT, a shower, everything what as per the recommendation that happens. If it is a non-emergent surgical admission, then it goes to a suspect ICU. It is a COVID suspect ICU where the patients are admitted. If even from the COVID operation, if a operation theater, if the patient gets operated, he goes to COVID suspect ICU post surgery. And if the test comes negative, then he comes to the neurosurgical ICU. But if the test comes positive, then he goes to a dedicated COVID ICU. Now, as a neuroanesthetist, we are handling patients in emergency, COVID operation theater, and neurosurgical ICU, while the critical care team they looked after the COVID suspect ICU and the COVID ICU. But we have a very good telemedicine facility available. Even if we are required, we or the neurosurgeon, so then we can pitch in the COVID suspect ICU and COVID ICU first by telemedicine, and if required, then we need to wear the PP and see the patients there also. So at all the at whatever level the patient is in the whether he is in emergency room, whether he is in COVID operation theater, COVID suspect, at all the facilities appropriately required personal protection gears are provided to the nurses as well as the doctors and even the GDA. So in that, while in emergency room, if the patient is coming, then the nurses they are provided with protective shields, N95 mask, gloves, and a gown along with the goggles. While at the other three level, like an operation theater and suspect ICU, COVID ICU, appropriate level PPE along with the other protective devices are given to the all the healthcare workers. Even for transfer of these patients, a code green is activated in which the concerned departments they are informed that the patient, whether the patient is going for CT, whether the patient is being shifted to COVID suspect ICU, if the patient is going to operation theater, coming back from operation theater, then a code green is activated in which the concerned departments are informed prior to that, 5 minutes before that thing, all the traffic on that corridor is stopped, the lifts are stopped, when the patient is transferred, after the transfer, the whole corridor is sanitized, and 15 minutes after that, the routine people they can move on that corridor. I'll be sharing a few patients and what we got operated. So, a first patient was a 23-year-old young man presented in the emergency room with history of road traffic accident. NCCT head showed a left extradural hemorrhage, and he was posted for emergency craniotomy. Uh, so the patient on risk assessment as per the ICMR guideline form was low risk. But as we are sending all these tests, COVID-19 test was sent for him from emergency, and then the patient was treated as suspect and he was shifted to COVID OT, where as per the protocol, all the precautions were taken and he was operated in the COVID operation theatre. Later on, this patient turned out to be COVID positive. Now, as per the protocol, Hospital COVID Surveillance Committee did interviews of all the healthcare personnel involved in the management of this patient, in whether in the emergency room, whether in the operation room. No major breach was noted because the protocol was in place, but there were some minor breaches were noted. So we needed to, out of 27 people involved, healthcare workers, there were potential minor breaches, and they all were sent to home quarantine. So the potential breaches noted were that while the surgeon was examining the patient in emergency room and the junior anesthesiologist went for TAC, they were not they were wearing N95 masks, but they were not wearing shields, and gloves were missed at some times. They, while examining the patient, they used the gloves, but while sharing file and pen for consents and everything, gloves were removed. While shifting patient, one nurse had worn the protective gowns, while others did not wear it. Post surgery, the three of the operating team members did not took shower, and they went to their respective places. So all these minor lacuna, they were identified. All the healthcare workers, they were shifted to they were sent to the home quarantine. Later on, they were tested at fifth day, and the report came negative. Then they were asked to join back duty after 7 days. This patient, he was sent to a COVID dedicated ICU where he was monitored by the telemedicine as well as the critical care team. He was his first test was came as positive. His fifth day again a COVID RT-PCR was sent, which again came positive. Because there was a change in policy by the Haryana government at that point of time. As per the guideline, he was to be shifted to a COVID dedicated hospital, but they somehow, for some reason, he was not shifted for next 7 days. They asked for that they don't have a dedicated neurosurgeon facility, a neurosurgical facility at that hospital. So the patient was kept here. After 10th day, he was shifted to the dedicated COVID-19 hospital, where he was discharged after the 14th day from there, and he is doing fine after this thing. The second patient, he's a 69-year-old gentleman with history of fall, came with progressive generalized weakness, especially right side weakness. NCCT head showed a left frontoparietal chronic subdural. The patient had no history of any exposure. He was again a low risk, but his first report came for COVID-19 came positive. He was posted in a for this thing, the whole evacuation of subdural hematoma. Since the patient had no history and very low risk of exposure, still we took the patient as positive. We simultaneously we sent a second sample for RT-PCR. This patient was done under monitored anesthesia care. A burhole evacuation with endoscopic evacuation of hematoma was done. We had no significant problems in this thing in the getting the case done, as all the COVID-19 precautions they were taken. And now the second report, it came negative. So we came in a diagnostic dilemma. What to do now? Within 24 hours, we had two reports. One was positive and another was negative. But we still treated the patient as positive. We kept the patient in COVID-19, COVID dedicated ICU. The other problem we faced was family counseling, because the family, they thought that the patient is exposed. Now after 24 hours we were telling them that no, the second sample has come negative. So whether they asked us whether we should go undergo a contact tracing or not. So it was difficult on part. It became difficult on part of the hospital to also do this thing. But after second sample was sent, third sample was sent after third day, and it also came negative. So this thing was sorted out. The better part was that because there was a hospital protocol for this COVID positive patient, no breach was noted on part of healthcare professional, and we sailed smoothly. Now, I'll be sharing two cases which we encountered as COVID suspect in the stroke DSA lab. DSA lab is a remote location, and we here it is a time sensitive zone. We can't delay the things. In OT, it still we get some time, maybe half an hour to prepare the OT. In DSA time, in stroke cases, we don't have this much time also. The patient is shifted straight from the emergency after the MRI, and we just have 5 or 7 minutes to do PAC, consent, and preparation of the DSA lab as per the COVID-19 precautions. So it becomes a very tedious job, and because only one person is allowed, so getting a team coordination is very much of paramount importance in this type of scenario. The first case was a 35-year-old gentleman with a sudden onset left-sided weakness. On DSA, there was a complete occlusion of ICA, a mechanical thrombectomy was done, and so a reperfusion was obtained. This case was done under monitored anesthesia care, and he was later on shifted to COVID suspect ICU, and later on his report came negative. The other case was a 29-year-old gentleman with history of sudden onset motor aphasia with a progressively increasing weakness of the left side. On DSA, M2 branch block, block was noted, reperfusion was obtained. This case was also done under monitored anesthesia care. So the problems we faced in DSA was because there was a very short time, only one attendant was available for PAC, and he was also a friend. So in both the cases, there was a doubtful history.
Dr. Virendra, Dr. Virendra,
Pardon?
can you just hide that blue button on your screen? That one down,
Okay.
it is coming. No, hide that. Yeah, hide
Okay.
it, hide it.
Yeah.
Yeah.
Oh, now
So
it's okay.
yeah, thank you. Yeah,
Oh.
thank you. Yeah.
The main problems we faced in DSA was that there only one person was available for at that time because of time constraints. He was a friend of the patient, so there was a very doubtful history for COVID. We took at it as a suspect cases, both these cases. Time management is an issue. We only got, in one case, we got 5 minutes for the patient. Another second patient, we got 10 minutes before the patients were shifted to other DSA. The third thing is negative pressure cannot be done in a DSL lab. There are 3 to 4 doors, and the entry exit of personnel is an issue. So taking precautions in DSL lab is of communicating everybody that okay, this is a suspect patient, you should take all the precautions. It becomes a paramount importance. Protective gear over a lead apron, again additional burden. Plus there are definitely communication issues because suddenly we have 6 to 7 people coming in the DSL lab with the patient and communicating everybody, okay, do this precaution, do that. It becomes sometimes a cumbersome issue. The other issue we had planned that okay, if the patient is, if we have time, then we'll be intubating the patient either in the COVID OT or a isolation room of ICU, and then we'll be shifting to the DSL lab. But seeing all these, both these cases, I think this is practically not possible because the time we get is very much less. If we shift the patient to a COVID dedicated OT, do the intubation there, and come back to DSL lab, crucial time is lost, which is which becomes impractical in a stroke situation. Now, this is the SOP for the COVID dedicated OT. So in it, as per it is a negative pressure OT. It has only a single entry and exit. There is a separate donning room. The operating team is donned before the patient arrives. Only the anesthetist and technicians are allowed in the OT during intubation. The people inside the OR are not supposed to leave the OR till the case finishes. A runner is there to ensure the supply of consumables from the window in the corridor to the OT. But this runner doesn't enter the OT. A technician is stationed outside the window to supply consumables from store to the runner, and only required consumables are kept in the OT and leftovers are discarded. So in this, as you can see, we have covered all the anesthesia workstations and all the required monitors by the disposable plastic cover. What I want to highlight is in the coming slides, I'll be discussing regarding this instrument also, what we have developed. This is a negative aerosol for negative suction for the aerosol prevention. So I'll be discussing regarding this also. I don't know, maybe this might be of this machine especially, but uh, the changing the knob settings in the ventilator settings is because this plastic cover gets stuck sometimes in this knob. So we faced in one patient, this was a practical issue, even in the Philips monitor also. So sometimes changing the characters, it becomes sometimes difficult. The window from which the supplies are supported inside the OT, and the runner is with the PPE kit. In the dedicated OT, though the high volume air volume exchanges are recommended, in that more than 12 are recommended, but we are doing a 30 volume exchange in an hour in our OTs. It is a negative pressure OT, and now, this is a familiar picture in all the suspect cases. What I want to highlight is now what the surgeons have done here is the sleeves have been cut by them when they are wearing the PPE, and they are wearing a long gloves because in PPE there is a sterility issue. So in that, what we have done is that they have cut the sleeves. They have worn the long gloves after scrubbing for properly for 3 to 5 minutes, and now above that they'll be wearing the sterile surgical gowns. Now this is the aerosol prevention device. Like we have been using intubation boxes for intubation and extubation for aerosol prevention and prevention of contamination. And what we found, we have 2 intubation boxes at our institute, but what we found the problem was that they were too rigid. There was very less flexible for the arm movements during intubation, and we faced a problem maneuvering the sometimes tube and this thing. Plus, they were too bulky and heavy. So to prevent this, we, as sir told, we along with our senior neurosurgeon, Dr. Rana, we have developed this wire mesh thing, which is basically it at the end of the assembling, it forms like a canopy in which this thing. I'll just show how the video this works. So this is made of steel wire. At various joints, it has been intertwined, and this thing we are applying a plastic cover from below. These are C-arm covers of 50 rupees each, and one is applied from below, the another will be applied from above, so that enclosure is formed. At the base, we are given an incision for the patient's head, this thing. So now from the above, we are enclosing this from the plastic sheet. Now it is stretched, and we are tying a bandage with the L connector that we are using inside, commonly seen in neurosurgical OTs. Here we have used these are 3D printed copolyester rings, which we have made, and these have been with the superimposed over the plastic sheet. And in this, we will be making a Mercedes-Benz incision, and through that the hands will be accessed, and we will be accessing the patient. I'll be showing it in the video also how this thing works. So once the patient is positioned in the aerosol containment box, we do the pre-oxygenation, keeping N95 in place, or we prefer rapid sequence induction. We are using video. We were initially using video laryngoscopic blades. McGrath was there, but suddenly there was a shortage of disposable blade of McGrath. We only had 5 blades in our hospital. Then we got a disposable blade of normal. This is of 500 rupees, 500 cost. So now we are using a disposable blade for all our patients, and if needed, a video laryngoscope. This thing. This blade is resheathed immediately after intubation. Gloves are changed immediately post extubation, and we are using the high HME filters as recommended. So in this, when we are using the aerosol containment device, you can see how the thing works out. The patient is being ventilated, and the canopy is hang from the angled bar, and a clear view is obtained, and this thing simultaneous. As we can see, there is a total enclosure from both from above and below. The only entry exit point of the aerosol is from these rings. If needed for another help, then we can add another ring above in the front of this thing for a technician access if needed. Even the technician can help from outside the sheath uh, without creating a space for himself. So everything is being done under this canopy and no aerosol contamination is being done. So what we think as advantages in this, that it is a better stabilization. As we can see, we have given an extra loop below the head. So this extra loop head wire, a steel wire, it gives a better stabilization because this goes under the head ring and the head of the patient. So it provides a stability to this whole system. A clear view to the anesthesiologist. It is very flexible. You can change, and you can even, it is malleable also. If for a heavy patient, this can be a heavy patient can be easily accommodated because the it is a plastic material, so it provides better hand coordination, and even the spaces between the two hands can be adjusted. It is very easily assembled, cost effective, autoclavable, and reusable also. And during its use while extubation and intubation, negative pressure suction can be easily applied, which prevents fogging and also aspirates aerosols. And even for the height also, it can be adjusted because we have a stand from which it can be hanged, so it can be adjusted as per the anesthesiologist requirement. So we have found it to be useful. We are regularly using it. Now the other thing, the only disadvantage is which we have found is that it takes around 5 minutes to assemble. By putting the sheets, hanging it. So in an emergency intubation, it can be slightly tricky, but otherwise it is very good. So we are using low flow and closed circuit ventilation, avoiding unnecessary disconnections, and ICU team is informed about the patient beforehand. About generally we inform about half an hour. Here we inform an hour ago, so that they also have time for preparing the beds. Now coming to this is the anesthesia part, because neurosurgery is also associated with high-speed drills, use extensive cautery use. All these are potential aerosol generators. So for surgery also, they have specially designed a special aerosol containment device with a port for high pressure suction, so as to create negative pressure inside the operating area, so that the aerosol dispersal is less in the minimized in the operating room. So here again, it is the same, more or less the same wire mesh device, but they have made it more robust and this thing for the surgical requirement. This is all autoclaved at the onset, and then it is assembled in the sterile practices. Here we can see the surgeons doing the drill, and a suction is also applied, plus a third assistant's access is also there, where he can provide the instruments also, and he can do the suction. Now I'll be highlighting, this is the negative pressure suction tube which you can see, and so this suction tube is then connected to this source, which is then connected to a high pressure negative pressure suction, which has been specially imbibed by which has been specially built by our biomedical team. So this provides an extra negative pressure suction, so that all the aerosol which is generated in the operative area, it is negatively aspirated and thrown out of the system, so that the exposure of the aerosols to the other healthcare workers is minimized. So whether this system works or not, we have made it, but whether it works or not. So to validate or to see the effectiveness of it, we have done how we have used the air particulate counter. So what is the aerosol generation at various stages of this thing, of the patient movement and under anesthesia and under surgery. So we did this thing. So if the patient is just lying on the table, he's at the center of the OR, he's under laminar flow. So as we can see all this monitor, so this is the air particulate counter which is procured. It is about 1 lakh cost. So it takes around 20 seconds to aspirate the air, and it gives a calculation. So here you can see the 0.3 micrometers. It is 1449 49 ppm, and the 10 microns is 1 ppm. This thing. So when this patient is transferred, it was spontaneously breathing with no cover. When it goes under cover, it spontaneously breathing, the value changes from 1049 to 939. Similarly, the patient this was for video for just demonstration. We have done this patient under, this was a hysteroscopy patient. A ProSeal was inserted. So in this, after 10 minutes of ProSeal insertion, the particulate matter has decreased from 939 to 252. This was for anesthesia. Now CBC, what happens under neurosurgery? So in neurosurgery, if we see that during drilling inside the tent, the amount of aerosol generation is, just see at the figures, it is 1,30,440. So this is the amount of aerosol that is being generated when the drill is being used at 75,000 RPM. So this is the potential exposure which all the healthcare workers are exposed for, this aerosol generation, and we are all wearing N95 and protective shields, but still this is a quite large amount of aerosols. So when this drilling is happening, what is happening outside the tent? When we are using, this is the 0.3 micron count. This is 672. So while inside the tent we are seeing a significant number of particulate matter aerosols, but just outside it is very quite safe, just as we are using. So, and this is the value which we are seeing when we are moving inside the corridor. That is about 8,758 particulate matter. So this shows that, okay, whatever system we are developing, it is effective and it can be useful for aerosol prevention, and especially in COVID-19 scenario. Post surgery, all the patients are preferably extubated in the operation theatre itself in the aerosol containment device. If extubated, then the face of the patient is covered with the mask, and if not extubated, we use the portable ventilator to shift the patient. We generally try to avoid vein circuit as far as possible. The patient is received by the ICU team on the OR gate, and they are also wearing the protective equipment. After the completion of the surgery and the patient is shifted from the OT, then all the OR team that it doffs the PP carefully following the protocol and takes the shower before leaving. All the PPs are properly disposed. All unused items are considered as contaminated and discarded. And after that, proper sterilization protocol is followed. What issues we have faced in this thing in for last 1 month, that whatever we do our best, there is a chance of breach of protocol. In OT environment, we are following it very strictly, and touchwood, no major mishap has happened. But there are chances that, especially in emergency room and ICU and even in transfers, there can be minor glitches which still should be prevented. The communication between teams can be an issue. Emergency team, OT team, anesthesia team, surgical team, and ICU team. The communication has to be clearer and well in advance. because we have faced that we have waited for 1.5 hours inside the OT wearing PPE just to get the bed from ICU, because somehow the bed was not ready and the staff was also not ready. So the so we gave the late communication to ICU, so that we have to wait for an extra 1.5 hours just to get the bed inside the OT. Temperature maintenance is an wearing PPE can be a very difficult situation, and also in DSA. These were minor issues which we found in initial cases, that there was no mirror in the donning room. We could not see what PPE, how is there any gap or this thing. This was sorted out very early. Telephone, pen, unit, all these were minor issues which were sorted as we practically did the cases. The most important is, as the ICMR changes its recommendation, the quarantine and the hospital quarantine guidelines also change for the hospital. So every day, every week we get a new quarantine guidelines. So how to go about it? This depends on the day you are operating and how the this thing. What is the current recommendation of these COVID guidelines? So my take-home message is handling COVID-19 patients needs a greater teamwork than the other patients, and a communication at all levels should be well established. Individual hospital-based policies should be implemented based on the available resources, and breach of protocols should be avoided at all levels. Not only anesthetists, surgeons, even the OT technicians, nurses, and the junior staff, all they should be well trained for to prevent a breach of protocol. Stay safe. Thank you.
Thank you, Dr. Virendra, for that wonderful presentation. And it was really nice to see that. And a lot of questions were there from the audience, and a lot of people joined in from Facebook and YouTube. I must say, lot of our, of course, most of them are sir students who have joined in, and there are a lot of questions for sir also. Sir, do you want to make some final comments before we go on to some questions by the audience?
No, final comments is that the particles which we have got recently, that I was suggesting, Dr. Virendra, if you can do some studies before we must measure it inside the OT, then inside the hood,
Tent, yeah,
and,
wood.
and during the procedure, then that will be a very good study from our center.
So, sir, is it a medical grade equipment? The particle counter, what you are telling, is it a medical grade equipment?
Yeah.
It is a this
Or
thing.
is it? Hmm,
No. This
hmm,
particulate counter has just recently came. It came only 3 to 4 days ago. Our neurosurgeon, he has personally bought it. He wanted to see how much aerosol generation we are doing under this thing, because we are in
okay,
very close communication regarding the development for intubation and extubations also. So
okay,
we requested him for this thing also, that how we are doing for anesthesia purposes also. Similarly, for
okay.
surgical drilling and all those things, we are using it. This has been done only 1 day ago, so we are still to see how the results finally go. But yes, we are seeing quite a difference in
Quite
the
dramatic.
dramatic difference of aerosol generation that we are seeing.
Okay. This,
So
yeah.
now my recommendation will be only whatever the instrument you have, you should be using, whether it is an intubation box, whether even if it is a sterile drape also, a plastic sheet also, because aerosol is such a thing, and we are in such a close communication with the patient during these procedures, that we are at very high risk for this thing, for aerosol contamination.
Yeah.
I'll, if Prasanna, if we can ask Surya Dubey also, because he
Yeah.
has he
And then after that, we
after
can have
that we can
discussion.
have a discussion regarding this thing.
Yeah. We have Dr. Surya Kumar Dubey. He is a faculty in AIMS. So, our own colleague. So, he would like to make some comments. Yes, Dr. Dubey ji.
Good afternoon, everyone, and good afternoon, Das sir. Thank you, Dr. Prasanna. Well, my experience in managing a COVID positive patient in an operation room is so far restricted to surgical tracheostomy only. But still, I want to share my experiences, and I want to share some tips that can be helpful as well. As we know that tracheostomy is one of the procedures with high aerosol generating probability. So in our institution, we have now developed a protocol to do surgical tracheostomy. We are not doing percutaneous tracheostomies for these patients now. And the case which I was involved was a case elderly patient more than 70 years with diabetes, hypertension, and the indication for tracheostomy was prolonged mechanical ventilation only. So what we did, from the intensive care unit, just before shifting the patient, we had given adequate amount of muscle relaxant and opioids, and we transported the patient from the intensive care unit to the OR with a transport ventilator. Well, again, we are not using vein circuits or any other circuits for patient transport. And inside the OR, the major problem what we faced was due to the fogging inside the PPE, and all were using level 3 PPEs. So it's not only the surgeons also face problem, because in that procedure we had a bleeder, and the surgeon took a lot of time to control that because of inadequate viewing. And a few things I want to share that we also load syringes from outside and take the syringes and drugs to inside, and we keep the drug minimum inside the OT. So we have a normal tendency that we stick micropores, and we write the drug names and all that. So once we go into the OT and fogging develops, all the syringes will start looking alike. So my suggestion is that you should be using a color-coded drug labels. That will be quite useful. The second thing is that when we disconnected the patient from the transport ventilator and transported to the OR table, we kept the catheter mount with a filter attached so as to avoid aerosol being dispersed to the surrounding. And the third important thing is that due to the fogging, the monitor parameters were also not visible after some time. So what I suggest, if you use multiple parameters which are vital for you to monitor, then better you set an alarm limit for that, so that when the alarm goes in, so you can have an idea that what approximately those values are. And needless to say, one practical thing, what Virendra said already told, that temperature inside the OT and the communication between the teams is also important, because in our center, being a dedicated COVID hospital, we have a dedicated donning area. After that, from that donning area, we have to go to the OR. So by the time we enter into the OT, if there is a delay between the patient transfer, then by the time patient reaches to the OR, already the fogging sets in. So if you can cut short that delay, so that you can have fogging-free condition to work in those conditions. So we don't. So far as the intubation is concerned, if at all, so we are using that intubation box. And as far as practical, we are avoiding extubation in the OR. We are shifting the patient to the intensive care unit, and after some time we are extubating the patients in the OR, and keeping minimum minimum movement of persons inside the operation room. These are certain things that we.
So what is one particular thing we are doing when you are doing a tracheostomy? When you withdraw the tube and they make one incision on the trachea, a lot of generation of aerosols will be there when there is a positive pressure ventilation. Are you clamping the tube and cutting off the ventilation during that time?
Yes, what we were doing that just after the surgeons, they complete the dissection, before giving a rent, we are giving additional doses of muscle relaxants, and we are stopping the mechanical ventilation for that brief period till they insert a tube and inflate the cuff.
Is it not advisable to avoid open tracheostomy during this pandemic? Why can't you routinely do PDTs for all the patients?
Well, sir, PCTs has got its own disadvantages also, because it is expertise dependent. Second is that if there is intra procedure complication, then in a setup which is not probably equipped with larger lights and cauteries, bleeding is difficult to manage. Third is that there are certain unique complications with PCDs, like guide wire kinking, guide wire entering into the tracheal tubes. So these are the problems that will compound, and in
No, no,
express
I'm not
situation.
talking. See, all the procedures has got problems. Just want the opinion of the house because it is generally
No,
said that the aerosol
Puraya,
generation is less than PTs. Is that true?
no. Theoretically, if you see the aerosol generation is more with PDT, percutaneous tracheostomy, because multiple times you are dilating and coming out, there is a patent airway for longer time and the ventilation is going on. Whereas in the open tracheostomy, you can clamp the tube, stop for a while and put the tube. There is slightly we can modify the procedure in open, whereas that control is less in a percutaneous tracheostomy.
Yeah,
And
exactly.
in a patient where, yeah, in a patient where you are more worried for all these things, better to be go for a safer option than the. And yes, Virendra,
I
Dr.
think we.
Virendra, yeah,
I
sorry.
think I will go for a percutaneous
Mm,
tracheostomy. You can
yeah.
easily do it under in the isolation room. Regarding the aerosol prevention, yes, if you are doing it properly, I think clamping of tube can be helpful. Multiple dilatations is dangerous, but if you can do it in a single attempt and if this thing can be done, it can be easily done. I don't think we should be exposing these patients if not required. If it is required, then it is okay to the surgical tracheostomy, because there are too many persons involved. In percutaneous tracheostomy, only 3 or 4 persons, they can easily manage this thing and easily it can be done inside the ICU. This is my personal opinion.
Yeah, this, yeah, Pune. So, that is true, but yeah, Manish has joined in us. There are a lot of personal opinions, and Manish is yet to join.
No, there are
So,
other
there were a lot
questions as well.
of,
Some
yeah,
questions.
yeah.
Yeah, one by
I
one.
will go one by one, yeah. So, most of the questions were concentrating on this interventional neuroradical procedure, particularly for stroke. What you explained, where do you do donning and doffing, and where you intubate the patient? That was the question. If at all you have
Okay.
to give GA, what is your plan? Like, where do
Okay.
you do donning and doffing?
So basically, in our DSL lab, generally we don't have a changing room, but there is a separate store room which is just attached to near to the washing area. So we have made this as a temporary donning area, and this thing, and for the doffing, generally we are trying to doff in the neuroradiology lab only after the procedure is over, and we just come out of this thing. And regarding the shower also, there is an issue,
Yeah.
but we have tried to address this issue, but still we have not been able to find the complete solution. Luckily, both these patients, they came out negative, but if they would have come positive, yes, there would have been issue, because we would have potentially contaminated the corridor, because the shower area is in OT, but both the lab and the OT, they are very adjacent to each other. So this is a short distance, just about 10 or 20 steps from the DSL lab to the OT complex. So this is an issue which we have still not found the correct answer. But yes, this is the second
No,
question.
yeah.
The intubation plan, what we have initially, the neurosurgical, this thing, the suspect ICU, it is just opposite the DSL lab. Okay,
Yeah.
so it has a dedicated isolation room where there is a negative pressure can be created, and this thing. So what we have initially planned that we'll be intubating these patients either in the isolation room of ICU, suspect ICU, or if time is available, then we intubate the patients in the dedicated COVID OT, because all these three places are very nearby. These are just uh, 10 to 20 meters away from each other. So then these patients can be shifted to the DSL lab. But both these cases, we didn't have the time. So the other rescue plan was that if we need to give GA, then it will be done under the aerosol prevention box, and we'll be taking all the due precautions, whatever can be taken.
Yes, Dr. Manish, do you follow the same protocol in your institute?
Yes, the protocols are almost more or less the same. We have again for suspect areas and which are closer to emergencies, and then the patients are shifted to OT or cath lab in emergency. We use full PP, and then the patient is shifted back. So this is how things done, because till now, ours is a green hospital. We do not have any COVID positive patients. The patients who turn out to positive and the patients who are diagnosed to have COVID, these patients are transferred to some other hospital. So
Okay.
till now we have got many patients who incidentally were also having COVID, and few patients who had pneumonia and then were diagnosed as having COVID, but all of them were shifted to other hospitals. So
Okay.
we do
Okay.
not face.
Okay. Dr. Dash has a point.
See, actually, I'm wondering how you people at the institute or maybe JIPMAR managing these patients, particularly for the neuroradiology, because there is no
Yes.
facility, if I remember correctly.
No, no, sir. We have a dedicated hospital for COVID of 250 beds,
Acha,
and
in that
we
case,
have a CT in the 128 slide CT in that building itself, which we have now currently designated it for COVID patients. And we do get most of our admissions there who are suspect or positive patients in that building. We have currently around 12 positive patients, I think, and one is on ventilation, mechanical ventilation. One is on oxygen therapy in the ICU, and lot of patients. If you compare yours, that we get lot of this pregnant patient for cesarean section from the contaminant zone, and they will have breathlessness. We did almost, I think, around 15, 16 cesarean sections in the last 2 weeks, and I think two head injuries we had to do. Apart from this, we faced some of the unique things, like one of the 34 weeks pregnant patient had a road traffic accident, and she was hit by a lorry. She became even VT and M1, and fully full brain damaged, cervical spine fracture, everything. Now she is pregnant, baby is alive, she is unstable. We have to do a cesarean section for her to save the baby. Okay, that was the issue, and this patient cannot be shifted to the COVID block, COVID OT, which there is some distance, cannot be shifted to a cesarean section. OG cesarean OT is a different one in a different building there, and now it is in the emergency. So we had to do this in the emergency OT using all the PP. We face some more unique problems than this. So it's actually the spectrum of things what, because I was very happy with the way Dr. Virendra presented. I was myself involved in the COVID OT preparation in our hospital. A lot of these things were we also thought, and every day some new problem is
Yeah.
arising, and we are trying to address it. That is the issue. Yeah.
Initially, like the first time, the phone was outside the
Mm.
OR. So for two
Yeah.
cases, we could not communicate it
Mm.
inside the OR, outside. Like if
Right.
I am outside, I could not communicate
Mm.
inside the OT what's happening. So then
Mm.
next time, on the third case, we got the telephone inside the OR. So all these things,
Yeah.
when we are doing cases and we are regularly following it up, you have
Mm.
to be very in close communication with the hospital committee so that you get all
Mm.
these things lined up.
Yeah.
So, Dr. Virendra and Professor Dash, sir, to respond to your questions. So, we are also collected a lot of experts from our side, and we are trying to find out what is the practice in the institute, because this is a situation where we really don't know. Everybody is new to the situation, and now what will work best in this situation. So, with respect to the stroke, at least, and other neurointerventional procedures, it has been a reasonable conclusion that we will not intubate, if at all possible, inside the INR suite. Most of the times, if the hospital has a negative pressure room, then that is fine. It is the best place to intubate the patient there and then bring the patient to the INR suite. But most of the hospitals does not have a negative pressure suite. Like when Dr. Virendra was saying he has got a negative pressure theater, then I was really wondering,
Yeah.
because
Very
that luxury is not there in many hospitals. There are some technical ways which we can convert the positive pressure into negative pressure theaters, but nobody is absolutely sure of how it should be done, and the validity of that and how it will work. And some people are of the opinion that we have to switch off the AC if the negative pressure is not there. And I don't know what is the validity of that also. The switching off the AC is really going to help.
Initially in
whether
our
we.
hospital also they thought that we'll be switching off the AC, but with one or two cesarean experiences and all those cases, it was very cumbersome
Difficult
with the
of
PP and
surgeons
difficult
and
to get. So then later on they started switching on the AC now, but still the temperature what we want, it comes at around, practically it comes at around 23, 24. Maximum for like chronic subdural, we would able to get it around 22. But still, the surgeons, they were sweating inside the OT. That was the thing. So
And then regarding the aerosol box also, initially a lot of people were publishing about the aerosol box, and recently few studies which are coming, it's showing that the aerosol box is actually not helpful and it can be counterproductive, make intubations difficult,
yeah, that's
and all
why
those issues are coming.
sorry, this was the problem we faced, because we also were using the intubation boxes which were suggested as per the various guidelines which came in this thing, webinars and the guidelines. So we got it made, these boxes, acrylic boxes, but from practical use we found it that okay, these are making our intubations difficult, and plus the whatever the sheet, because the distant part, it is all exposed. So if you are placing a sterile drape or a sheet, and then the technician is giving you some instrument or laryngoscope from down, then the purpose of it, all it is getting defeated. So that's why then, because the surgeons, they were developing this device, then we came up with this discussion that we make this for anesthesia also. So Dr. Rana, senior neurosurgeon, he has got a very technical mind. So he took around 1 to 2 hours to understand all these things, how this thing we need, and then he started developing this thing. This is still, we are developing it. We have got 3 or 4 changes done in this wire setup, but it is working that we are that we can.
Dr. Virendra, I think if you mentioned about using a aerosol hood even after intubation during the surgery, there were some questions for that, and Dr. Pandya wanted to know, do you take out the aerosol hood after removing the bone flap and opening the dura when the surgeon needs to operate on the brain, or the whole procedure?
No, everything is done under the aerosol box. Everything.
The surgery
Is also done under the aerosol box.
See, that you have seen that microscope, it is attached to the microscope.
These are two separate. One is for anesthesia specific, other is surgery specific. So after we have intubated, the anesthesia box is shifted out from the patient. After 10 minutes, it is shifted out, and then the surgeons, they prep the patient. Meanwhile, the surgical part is autoclaved in the autoclave room. It is opened in the sterile conditions. They make all these things in the sterile condition. Then this is adapted to the patient, and
No, the other question is about maintaining the sterility, and during drilling, when you're irrigating that, aerosol can result in fogging, and how those things were managed.
That's why for this thing, the negative pressure suction that is applied. All these are sterile tubings that we use for the our. Can I show this thing? I'll just share the screen, and meanwhile I'll just.
Yeah. Meanwhile, you can keep explaining also.
So these are all sterile circuit tubings that we are using this thing, and for the so as you can see here, we are using this thing. This is all attached to the microscope. All these drapes that these are sterile. This thing. So this is the negative pressure tubing that is applied here. This is just, it has come from the incision, and this, as you can see here, this is attached by a bandage, sterile bandage, to the microscope, and this the above opening is also the size of the microscope.
It is airtight.
Airtight.
So how about the sterility of the wires which are used to form this hood?
These are all autoclavable. These are all autoclaved initially before the procedure.
So for the assistants, it is not hampering with the surgical instrument manipulations for the nurses.
No. As you can see, they have made 2 additional openings for surgeons also, assistants also. This is for the main surgeon, his two hands are there. This is the third one from where he can provide the access for he'll be doing irrigation here. Here he is doing the irrigation. This is the assistant surgeon that is operating.
But Dr. Virendra, when with respect to this virus, this unlike Ebola and other virus, there is not actually a real viremia in this COVID. So such precautions, are we overdoing it, or it is absolutely necessary? So what's your thoughts on that? Because we initially start doing reaming in the femur, the bone reaming, fractures, surgeries, all those could cause aerosol generation. Yes, they cause aerosol generation. But apart from the airway, when these aerosols are generated from the rest of the parts of the body, except for the skull base or the nasal endoscopy and things like that, do you think in COVID patients where there is not much of viremia, even laparoscopies, they said initially it is very harmful procedure, but now they have come back and said that it doesn't cause much harm.
I think this we have to see, but I think the major surgeons who have expired are the orthopedic surgeons.
Orthopedic and neurosurgeons.
So
that is the
the answer should be lying in that question.
No, the thing is that they take the PP slightly.
No, we can't say that because these all were senior neurosurgeons and orthopedic surgeons, so we can't claim that their PP might have been defective or sort of thing. But so till we get enough data in this COVID-19 scenario, we are not sure. But if we can develop something, that will be helpful.
See, another thing, the aerosol measurement, the microparticles, that 0.3 microgram. See that increases enormously during the craniotomy and drilling procedures. So that is also another.
Even if the viremia load
it is a known factor that drilling causes increased aerosolation. The only this one, there is no conclusive evidence that those aerosols contain the viruses.
That is till we get enough data, we are not sure, but till that time we can use this thing. I don't
Prevention is better
than cure. That is the only.
The other thing is that so many people have called me and asked that in our hospital they're not allowing me to test for COVID. Only if the patient has symptoms for COVID, as per the ICMR symptoms, the lab is entertaining the sample. So, but according to your guideline, when I saw your flow chart, you said that all the emergency cases, you segregate them by COVID positive and negative based on the testing. So, can you just put some light on that?
Generally, as a dictum, all the patients who are getting admitted and who are coming to OR, we are getting COVID RT-PCR testing done. So this is irrespective of whether they are coming for an emergency or whether they are coming for elective surgery. So if it is an
emergency, it is only for surgery, or all the patients get admitted?
Generally, all the patients who are getting admitted, we are getting a RT-PCR done.
So for conservative medical management also
we are getting a RT-PCR done, and we try to get it as soon as possible after the admission, and this is sent, and after 18 to 24 hours.
Ask Dr. Dubey what they are doing in AIMS in non-COVID areas. How is your testing done?
We are not denying emergency surgeries for the sake of getting a.
That is fine. We are not talking about that. I'm talking about generally in non-COVID areas. What is your testing protocol?
If time permits, before every surgery, we are testing the patient for COVID status. So if time permits, then we are certainly doing that.
Why, Dr. Prasanna, you are laughing? What is your protocol there?
No, absolutely not possible. You cannot test like that. You will be behind the bars if you go by strict guidelines. Actually, we are not testing it. We are not testing. If we test like that, we will have around 1,000 to 2,000 tests per day. It is not that, we have a capacity of, I think, around 500 to 700 tests per day for our center. But the number of this RT-PCR kits, what they are coming totally from the central government, is highly limited. So if the patient has to come from a strong high-risk contact zone or has to have some symptoms, for asymptomatic patient, testing is absolutely, it has been said,
Yeah.
we will not do. Even we were doing for pregnant patient coming from a containment zone. That also has been said. If they are asymptomatic, no testing. That is
Maybe
the
that
uh,
maybe
yeah.
that we are doing
Yes.
because Delhi has become a red
I
hotspot
think
zone. The cases are rising like anything. So our still we are relying on the if time permits, we are getting tests done for the patients.
so
No,
these
I think
guidelines are
to
by national guidelines. It is not by us. Okay.
no,
So,
I
but
think
as of now,
to
yeah.
counteract Dr. Prasanna's viewpoint, it is by the Anesthesia Safety Foundation network. It has been very clearly mentioned that during a pandemic, especially in an area, if you're working in an area where the cases is not coming down, when the case numbers are not coming down or the curve is not flattening and coming down in those areas, when you intend to do any procedure for whatever reason, emergency or semi-elective or urgent or anything,
Mm, mm.
those patients has to be tested. It is a guideline that has to be tested
No, that
because
exactly the counter for this is we had around now 30 to 40 cases in the COVID OT, and we did all the suspected patients we took and sent the swab and took them as an emergency. None of the patient has turned out to be positive. It is a good thing, but they say that you are overdoing it. That's a counter argument. Of course, that there is no solution for this. I think we can leave at that, Pune, and there is no solution for that. It is the individual. See, if you are able to get it done, it is well and good. If you are not able to, then you take all the precautions, whatever is possible, and you do it. See, you cannot even ask for a.
okay,
Mm,
We'll leave aside and
mm,
ask Dr. Virendra. Sir,
mm,
because of this COVID pandemic, is the timing for any interventions getting delayed, especially during emergencies? Because
Uh,
you cannot have a team all the time wearing a PPE and waiting for the patient. Maybe an emergency room, it can be like that. So there are a lot of papers which have been published that the average time delay for especially acute ischemic stroke has gone up like something during this pandemic.
no,
So
in
what are
both
you doing
in
to
both these
alleviate that?
stroke cases, in both these stroke cases, I can only say the person inside, the anesthetist had only worn the PP. The intervention neurologist had not worn the PP at that point of time till the patient was inside the OR. Now, the only problem what is here is that we, because we had time here, because there was no other elective case going on. So one person went for PAC, other person he went to the lab, wore the PP and all those things, and he set up the lab along with the OT technician. So we had that time. But if you are doing it in the middle of the night, so then it can be an issue. Time delay, we are not. We are not. But
Not
it
encountered.
can have. We are not encountered because one patient it came in 10 minutes, other patient I think 15 or 20 or 8 or 10 minutes that way from the emergency. Now we have also asked the administration that if we can do the antibody testing, so at least we get some results quickly. But still, that as per the ICMR, it is not recommended for this is only a surveillance tool, so we are not doing it in our hospital. Only RT-PCR is approved. So this thing is time delay. We are not. It is not happening that way.
Not in
What encountered.
Sir, Professor sir, um,
yeah, yeah.
I want to add something because there are certain reports that are coming because due to this
Mm,
procedure, this preparation and all that, we tend to lose that IV thrombolysis time. So the IV thrombolysis window is probably lost in many of the cases, and the mechanical thrombectomy and all the other procedures are slightly performed more than IV thrombolysis because probably these procedures and all that they are taking time. Again, it's not large studies, but there are few case series that are showing this. That is one of the interesting finding that I happen to find.
okay, okay, good. Okay. So you mean to say that better to go for mechanical thrombectomy
No,
directly
no, no.
than the
I'm
IV?
not saying that because you are
Uh,
losing this window of IV thrombolysis. Then you have no other
mm,
option that other than to going for intervention radiology, and because the mechanical
mm,
thrombectomy window is slightly more as compared to IV thrombolysis. Only there are it's not
mm.
large studies, but this is some interesting case series that is been published recently.
Okay,
Okay, Dr. Virendra,
okay.
where can we get the particulate matter meter?
Pardon?
Mm,
Where
Okay.
can we get the meter?
Ah, So this Dr. Rana purchased, he got from Hyderabad. Okay, so Hyderabad, he has bought it, and initially he tried, but due to because the Delhi was a red zone and no courier services was operating, so he only got it last week, and since 2 3 days we have been using it. So he has, I think, bought it for around 1 lakh rupees. This has happened, but there are other variations also. So I'm not sure what is available in Delhi right now, because Delhi many. But yes, sir.
Okay, if you're done with that, yeah.
There are several particular matters are available in Amazon. Okay, for
Huh.
9,000 and 10,000. I don't know whether they work or not. I just saw
Maybe
cubic air quality
Chinese.
monitors,
So,
detector, pollution
so
meter
right
sensor.
now,
9,
so this thing because
9,000.
I'm so detailed discussion needs to be done, how or what all other this thing can be, because yes, Amazon, it is as you are showing it, it might be saying 10,000, or so maybe it might be the differential
So that is
different.
why my question was: is it a medical grade? Like, or like,
No. For this air particulate, what we for measuring inside the tent, what we have done is
hmm,
we have taken the sterile suction tubing. Okay, one
okay,
end has
hmm,
been connected to the air aspirator in the instrument, and another tube, it was the sterile, which was given by the nurse. Okay, so we made the
okay,
opening from the hands opening. It was measured inside the this thing. So this way
yeah,
we have measured the thing inside the tent.
yeah,
So
got
it is not a right now. It is not a. Ah,
Because Professor Das is also here, he can maybe shed some light on that. So I was disturbed by a few instances where, in one instant, one resident or a junior colleague, he tried to intubate a patient without a proper mask or something because he was not getting the vision in an ambulance. Was a known COVID positive patient. In another incident, an anesthesiologist was forced to remove her PPE because he lost vision during intubating a child or a baby. And a lot of people hailed them as heroes, somebody, and some people went back and analyzed and said that actually these PPEs, the way we are using it is still not appropriate. Because what happens is, if you see, especially the donning area, most of the times the donning area is doffing is done inside the OT itself, and most of the OTs doesn't have a separate doffing area. And when we doff inside the OT, it means you're exposed to all the aerosols which are already been generated. So in that instant, should we keep our PPEs very minimalistic and very simple, or are we overdoing the PPEs by creating more and more partition between ourselves and the patient, thereby complicating the things? And when things get complicated, you end up in deep trouble, like trying to remove your mask, remove your PPEs, remove your goggles, and things like that, which pose a huge risk. So now, what is an appropriate PP? It has to be simple. It has to be comfortable. It should not obstruct the vision mainly. So that is a major thing. And many of them complaints of obstructing the vision. This is a major issue in donning all these PPEs, and especially when
No,
it's not fitting properly.
I think whatever points you have raised, those are very valid ones. But the most important thing is safety. Safety of the anesthesiologist is paramount rather than. So, from the safety point of view, one has to cover properly whatever the prescription is there. This is my feeling. And one should not take it very lightly.
Right. So I
uh,
think regarding the vision, we need to have repeat. Say somebody was asking about, are you having drill? Are you having some drills in the hospitals? I think that is the most important thing. We need to have repeated drills, repeated practice.
That is yes.
so
That one
for
can practice.
like in our hospital, before any COVID patient came, even before lockdown, I think it was started around 1st of March. Lockdown happened around 24th of March. So there at that time, they've started the drills for the donning and doffing. So a practical experience regarding that fogging and all that. If I can show this photograph, they are putting additional micropores apart from this thing to prevent the fogging that happens. even on N95 and all those things. So it is what PP you are getting, because even PP gets changed. 1 week you are getting one type of PP, other week you are getting another type of PP. So it has to be a practical. This was in the first case. This happened that there was no mirror in the donning room. So the person wore the anesthesiologist wore the PP, but she was not sure whether she is getting a leak in the PP or not. So the sister, she helped her out. So still, that is a evolving situation, but you need to protect yourself every time. That is safety is of paramount importance.
So this some of the most people who have worked in this COVID ICUs in the abroad, what I discussed with them, what I conclude by their experience is that it is doffing is not doffing. We thought doffing is the most important. Now what they say, it is not the doffing is important. It is the bath, take bath after the doffing, which is more important. Don't go away without taking the bath, and don't touch the this one dress without
So
touching the dress. You just remove, take bath total, and put a new dress and get out. That they say that is the best. Don't take your hand towards a face till
yes,
you
so
take a.
there was a suggestion from our quality team that even if you are wearing the N95, you should not be touching it from outside, because you are harboring the infection at the most, and then these hands, they are even touching your body elsewhere. So this has to be it is a constant improvement. It has to be a constant endeavor. Everybody has to pitch in, and everybody has to point out. Today only I scolded my junior. He was he just removed his mask. He was talking. So why are you doing this? So he said, sir, I was doing this. So this has to be, it is a constant process. It cannot be one day or that, okay, lockdown one and now and COVID has gone down. So we can see that even after now, tomorrow lockdown 5 will happen, but still we are seeing a surge in cases. So it delays the cases, but we are potentially exposed to this COVID pandemic everywhere.
Yeah. Yes, Puneya, you have anything to ask?
No, that's, I think.
Dubeji, you want to make some comments? Yeah.
No, Das sir has very rightly said that your personal protection is also should be paramount importance, because if you lose the warriors, then who will fight the war? So, like should not be any compromise in personal safeties, because anyway it's a pandemic, it's an emergency anyway, but your safety is paramount.
Okay. So I think there's no point hailing ourselves hero in a situation where we remove the masks and things like that. We need to practice it again and again, so that such incident does not happen. Absolutely, and always we need to have some. Dr. Dash sir, if you want to conclude this with some of your remarks, then we'll close the session. So, yes.
No, I must give my again sincere thanks to all of you, particularly our main warriors of the ISNAC, that is Punaiya and Prasanna, two P's, a P square. So that we are listening to such a good discussion. And I think, as I told you, please remain safe first, so that you can fight this pandemic. And take personal protection, not only, personal protection also in the OT, that is very good for everybody, for all of us. Thank you.
Thank you, sir. Thank you, Dr. Virendra, for your wonderful presentation and sharing your expertise. I think there are a lot of questions coming, especially to share the food what you created. Maybe you can share it on our group. Okay,
So, Dr.
for them to go through it later on also. Okay. So
have you patented it? Have you applied for a patent?
Yeah,
right now not. We are just evolving the design. Yeah, but we have asked for Dr. Anna has asked for a commercial fabricator to look into this, how the things can be done because right now everything has been designed by him himself. Everything 3D printing, this thing, the rings, he has done. He has spent hours and hours for making this. For anesthesia only, he has made 3 designs which have been separately, and it has been evolving. Today only he gave us the 3rd one. So we are using it continuously and we are trying to improve it. Let's see. For surgery also, he has made
Yeah,
two.
I think Dr. Virendra, you can share all those photographs in our group so that people
Yeah.
know about that.
Yeah.
And so
No,
many
that-
people are. We also had a special session on the indigenous development in these things called jugards like that. But a lot of
that,
things
that,
are a lot of.
that we are trying to publish it in our ISNAC journal first. And
Right.
second thing I have told, we are planning, if we can do that particulate studies, that will be much more, and we may share it in our snack, webinar meeting in the
Right.
future.
Right. Most importantly, RT-PCR negative should not be taken for granted because there is a high rate false negativity. Still, we have to use appropriate PPEs in all the settings. That, all of us should take care of ourselves and our patients. When we are safe, then only our patients also will be safe. And thank you so much for the wonderful presentation. We'll meet you again in some other presentation. Thank you all for watching this classroom. If you have any doubts or any queries, please visit our page, follow our page, and please put your comments on that. We'll try to get answers for most of your questions as much as possible. Thank you. Thank you for watching.
Thank you.